A cross-sectional survey identified 11 common barriers to glaucoma eye drops adherence. If we look a bit closer, we'll see that the patients bear the primary burden of adhering to this treatment. So the question is, how can we achieve effective IOP lowering without reliance on patient adherence?
So laser is a one-off treatment. You know that somebody's had the laser. There's 100% compliance with laser.
This is Professor Gus Gazzard, Chief Investigator of the trial comparing SLT and eye drops as the first-line treatment for glaucoma and ocular hypertension, known as the LiGHT trial.
Well, we knew that SLT could lower eye pressure, but nobody knew whether or not it was better than eye drops or as good as eye drops. So I was trying to answer the question, not could we use it, but should we use it?
The trial took place across 6 hospitals in the UK. From over 16,000 screened patients, 718 were randomized into 2 groups receiving SLT and eye drops. Nearly a third of participants had ocular hypertension, and over half had mild open-angle glaucoma. Baseline IOP for both groups was around 24 millimeters of mercury. Both SLT and eye drop groups demonstrated a significant reduction in IOP, reaching 16 millimeters of mercury at 3 years. This IOP level was then maintained throughout the remaining 3 years of the trial.
What we saw in terms of immediate pressure lowering, medication first with a prostaglandin, gave the same 30% pressure reduction than did laser.
Disease progression was significantly lower in the SLT group compared to the eye drop group. Progression encompassed both ocular hypertension to OAG conversion and OAG deterioration.
The most recent unpublished analysis showed that there was a 29% reduction in visual field deterioration in the laser first group. I think it's a very useful figure to use with patients. Why do I want to have laser? Why shouldn't I have eye drop? We know it works as well at pressure lowering. There is this additional helpful effect in visual field preservation, which ultimately is what patients care about. It's whether they can see.
Among eyes that underwent SLT and achieved target IOP without trabeculectomy, 74% were medication-free at 3 years. This percentage decreased slightly to nearly 70% in 6 years. Of these patients, 55% required only 1 SLT treatment, while 35% required 2 treatments.
One of the most powerful findings from the study was that there was much less incisional surgery required for laser first group. And in fact, in the first 3 years, we needed no trabeculectomies at all for the laser first group. There were also many fewer cataract surgeries in the laser first group. It's been known for some time that certain medications seem to cause cataract if you treat patients for many years with pilocarpine, the old-fashioned drugs. But even with drugs that we're still using now, such as timolol, we know that there's an increased rate of cataract formation.
According to the 3-year data, treating patients with SLT as the first-line therapy instead of eye drops resulted in an average cost savings of £451 per patient. This saving is sufficient to fund SLT treatment for 2 additional patients.
I think if you take that outside of the UK, there will still be a lower number of surgeries, which is often the major part of the cost. There'll be fewer drugs required, fewer medications. The cost effectiveness will translate. What the actual number will be, that will be different for different environments.
Data from the LiGHT trial has had a major impact on glaucoma guidelines, recommending SLT as an effective first-line treatment.
I think in 10 years' time, we will still be using SLT as a primary treatment, whether it's DSLT or standard SLT. I think ab externo femtosecond sclerostomy is done with the Viola's flight procedure, isn't it? Really exciting potential option. Ab interno eczema sclerostomy is another form of MIGS, again, proving to be effective. But I think laser in the form of SLT is probably here to stay.